Welcome back to the channel HEOR with Sharma. In the series of Epidemiology for Health Economics, the current presentation is focusing on Introduction to Randomized Controlled Trial. Well, randomized controlled trials, as we know, that it's a part of an experimental study design and is considered as a golden standard for effective research. Well, I are going through the slides, thought it's better to go to a white page and try to explain it the traditional format or what a randomized controlled trial is and what are the few steps which are involved in it. So let's go through this PowerPoint presentation and let me try to explain what an RCT is. Let me change the color, blue color. Yeah, RCT, randomized controlled trial, golden standard. Okay, for effective research. Well, I hope you remember the evidence pyramid. For the evidence pyramid, just below the systematic review and meta-analysis, it's the RCT. The top position it is systematic review and meta-analysis. Yeah, it's working. So this is the evidence pyramid. Now let us try to go through steps in simple randomized controlled trial. Well, initially there was a huge population of interest with the indications which we are very interested in. Now, based on certain predefined inclusion, inclusion and exclusion criteria, out of this population, certain individuals have been which fulfills this inclusion and exclusion criteria, which could be considered as a sample, and then randomizations takes place. And usually, general, two arms have been created. One is the intervention arm, other one is known as control arm. Outcome has been determined, and then it has been compared which the intervention or control arm is having better outcome. Well, usually in the intervention arm, it could be placebo or the current standard of care. Now, as you can see that this entire step it's going forward in time. So it's very clear that these RCTs are always prospective in nature. So, uh, in nature. Now let us try to understand this sample. What are the different methods of sampling? Sampling method can be classified as under two broad heads, which is probability sampling and non-probability sampling. Under this non-probability, it could further be divided as quota sampling and convenience. Under probability sampling, it could be simple randomization. Oh God! Oh, I hope it's not been simple randomization. It's stratified randomization, luck, or cluster randomization. Now, this non-probability sampling is usually utilized for observational kind of study design. That is, probability sampling is used in experimental kind of study design. So, simple randomization can consider it as a flip of coin. These individuals will either be randomized to either intervention or control group. Stratified, similar to this simple randomization, but one more step is been included in stratified randomization, which is stratifying it based on certain characteristics Like for example, well, this is a sample, and then I have differentiated the basis of gender, that is either as male and female. And then I have further divided this into intervention and comparator. Similarly, these females are also divided its intervention and comparator. So this extra step is actually known as stratification. Now, block and cluster randomization usually take place when the area is too large, and then you need to convert those areas into blocks and clusters, and then those blocks or clusters are actually randomized. In non-probability kind of sampling, there is no statistical method or fixed procedure. It depends on the researcher. Times it depends on researcher's convenience, whether he or she wants males or maybe only females or any specific characteristics individuals. Snowball sampling usually takes place when we take one case and then we follow that individual, and then we ask that individual about similar kind of cases so that on coming bigger and bigger. Similarly, quota is also a kind of non-probability sampling in which we fix quota for that class, and only those individuals will be coming in that quota which has been pre-specified. So these are the kind of non-probability sampling which is like earlier told, it's used utilized in observational kind of study design. That would be a basic description of an RCT. So let's now focus towards that presentation and try to understand a bit more about randomized control trial. So as I already told that this method is going to be very rigorous because the pre-specified inclusion and exclusion criteria helps actually in determining in improving the internal validity of CT, because RCTs are having very huge internal validity. The result is that a very strict or stringent criteria which the individuals or the patient has to follow, then only they will be considered in the RCTs. Well, RCTs, as I told, are always prospective in nature, and it is useful in determining causation. Well, as in the previous lecture, I told that causations are not been determined through observational kind of study design. Well, no single study design can actually determine causation, but RCTs are valuable steps in actually determining the causation between effect and a cause, or the exposure and an outcome. Well, obviously, also I told that there is a process known as Hill's criteria of causation, which needs to be fulfilled before can very fully say that yeah, the exposure is causing that outcome. But this RCTs is one of the important steps in determining the causation. These are the steps of RCT. I guess it's not clearly visible, but the steps are similar to what I explained in the presentation, PowerPoint presentation. Writing, initially there is a huge chunk of population. Following the inclusion and exclusion criteria, the chunk becomes small, which becomes a sample, and then following the randomization process, individuals are being classified either in intervention or the comparator group, and then the outcome is being determined, and then it has been compared which outcome is better, either the intervention or the comparator. Now, this is an important section of an RCT, that is concealment. There is one more thing which is known as blinding, which is a bit different than concealment. What happened in concealment that prior actually enrolling into the study, the individuals or the participants should be unaware of what interventions or the control group they are going to be put into. To maintain concealment, usually the participant just before they are being recruited into the study means randomized to either intervention control group. It has been usually taken care through sealed envelope, opaque letters, which has been which are usually given to the participants. Through that only they come to know whether they are in the intervention group or in the control group. Actually, this helps in reducing the bias, because there is a possibility if the individuals know that they're being randomized to the intervention group, then there are certain possibilities that they may take care of themselves a bit more, and that might actually hamper the outcome of the study. Okay, now this is not a very strict rule that the only two methods of analyzing RCT, which is known as intention to treat and per protocol analysis, whereas intention to treat actually means the number of individuals which are randomized to the intervention and the control group are being analyzed, even if they are not taking the treatment or they drop out because of any reasons. So this is known as intention to treat analysis, whereas per protocol analysis mean only those individuals which have completed the intervention are analyzed. Well, intention to treat analysis are considered better because it helps in actually determining effect, because in real case scenario there is a huge possibility that when if you give the medication the patients might not completely take it. So that's the reason my intention to treat analysis are considered superior compared to that of the per protocol analysis. Well, types of RCT, I mean, I didn't said this thing earlier, so could be classified in multiple ways, but in general, you can consider it as a parallel RCTs in which intervention and control group are being really in what to say are parallelly being observed, and then the outcomes have been checked after the study has been completed. Whereas in crossover study design, what happens after a period of time, after a period of washover time, the intervention group is being given the control either the placebo or the standard of care, whereas the individuals which were in the control group were given the intervention, and then they are again being checked for the outcomes. No, non-equivalence and non-inferiority RCTs actually means the control groups are not placebo. It is actual drug or the standard of care, and then the intervention group is at least not worse than the new treat. Means the new treatment is not at least worse than the existing treatment. That's what has been determined in the equivalence and non-inferiority RCTs, whereas off-label trials you might have heard a bit about this a lot during the COVID time, in which a lot of drugs were actually being tested for COVID-19 treatment. They were not been researched for treating COVID-19, but as that time there was drastic need of there was drastic need of certain drugs which could be utilized for treating COVID-19. So those kind of studies in which the drug is being used for some other indication which is not been approved by the regulatory agencies is known as off-label trial. This steps has already been explained, which is simple randomization, stratified randomization, block randomization. Let me restate those words again. In simple randomization, it's just basically a flip of coin or computer-generated number through which the individuals are either been randomized to the intervention or the control group. Stratified randomization, there is one more step been added in which we are stratifying the sample either based on certain characteristics, maybe demographic characteristics like urban rural, young old, or male female. And in block randomization, we usually do this block or cluster randomization when the sample size is huge, and we are clubbing the individuals as block, and then we are randomizing those blocks, and then we are trying to find out whether the intervention was beneficial or not. Now, this is something which we should be aware of, and we are also interested in. That is blinding. Blinding is very much needed to actually uh, uh, to say that the outcomes are unbiased. What happen in case if there is not proper blinding has been taken care of? Usually, taking qualitative outcome, there is a huge possibility that the healthcare worker, if they are aware that the individuals are having either in the intervention or comparator group, they can hamper the outcome. They can ask the question in such a manner that the intervention group individuals may give a better outcome, whereas the control group individual may not give a better outcome. So this even if the intervention seems to be superior, it's not due to the intervention itself, but it is due to the bias of the healthcare professional which are taking the data. It doesn't hamper that a bit if the outcomes are quantitative, like hemoglobin values or your biomarkers. But it do hampers mostly during the qualitative kind of outcome. Well, blinding can be divided as single blind, double, triple, or quadruple blind, or single blind in which participants are only blinded, double blind in which participant and researchers are also blinded, triple blinding, which means those individuals which are doing the analysis are also blinded along with the participants and researcher, whereas quadruple blinding actually means the participant, researcher, the person who are analyzing the data along with the individuals who is allocating or overseeing this entire process. Usually, the organizers are also being blinded. Well, what are the null and alternative hypotheses, and along with that, what are type 1 and type 2 errors? Null hypothesis actually means that there is no difference in the intervention comparator, and both the outcomes will be similar. That there will be no difference if you allocate an individual in the intervention group or to a control group. The outcomes are going to be the same. Whereas alternative hypothesis actually means the intervention is going to be better compared to that of the outcome. Sorry, compared to that of the control group. Uh, this is the alternative hypothesis which the researcher wants to be true. Well, what is a type 1 error? Type 1 error actually occurs when you fail to reject the null hypothesis, which is actually true. In simple terms, it means, let me try to explain it with the help of 2 by 2 table, which will be better because this about it. Now, let us take an example when the actual case scenario it's true and one case is false. Now, after the research, there's a possibility we reject or we accept. Well, the actual scenario was true, but we have rejected the research hypothesis. Then this becomes a type 1 error in which we reject the null hypothesis when it was actually true. Whereas type 2 errors happens when we accept the research when it was actually false. Means the actual outcome was supposed to be false, but because of this certain bias or certain drawbacks in conducting the research, we actually accept the outcome, and it becomes a type 2 kind of error, also known as beta error and alpha error. So these things you should be knowing. You should be well aware of what is a type 1 error and type 2 error. Now going back to the presentation. Yeah. So this is, I guess, the end of the presentation, in which we will be trying to understand about the advantages and disadvantages of an RCT. Well, it's very clear the RCTs always takes forward in time. It's going to always be prospective in nature, as told that there are a lot of stakes in RCTs, so the amount or the financial constraints are also going to be higher compared to that of observational studies. There is going to be very high internal validity because of strict inclusion exclusion criteria. Uh, then it could be a drawback because there will be very low external validity and generalizability cannot be done as that of an observational study. Prospective data collection, that's okay. The duration of follow-up is usually less because it's very difficult to uh, keep the individuals in a constrained environment, or because we need to take care of certain things and randomization need to be taken care of. So that's the reason the duration of RCTs are small compared to that of observational studies. One of the advantages of RCTs could be it's helpful in determining the causation of exposure and outcome, whereas the disadvantages could be it's a bit difficult to uh, include rare individuals because anyway they are very limited in numbers. Hence, RCTs are usually not conducted for rare diseases. Along with that, there are certain inbound, what to say, ethical consideration while doing an RCTs because you need to take care of a lot of things if you're planning to do an RCT. And if the intervention is having a positive effect, then there is an ethical consideration why not to give the intervention to both the groups, why to make the control group not utilize those intervention when it has been proved that that intervention is having a positive impact, even if it's small. These are the ethical consideration or disadvantages in RCTs. Even with these disadvantages, RCTs are still considered as the golden standard and has to be done before any drugs actually hit the market. Thank you so much for a valuable time. I hope we will meet soon with a new topic. Till that time, take care. Goodbye.